maybe I can turn now to Dr. Cannon then. From a payer perspective, it seems like there's good data that we've discussed and cost effectiveness. Do you actually utilize or force utilization of different clinical care pathways or protocols to treat patients at high cardiovascular risk? And is that any merit in that approach to not only improving care and outcomes, but reducing costs?
Yeah, you bet. I mean, I think if you look at the way we're delivering healthcare today, and if you look at Select Health, which is part of the Intermountain Healthcare system, 40 to 60% of the business that is now coming into our system is in some kind of prepaid healthcare format. And so risk is shared between the plan and the delivery system. And so as we develop guidelines and pathways and protocols, I think as we talk about, and I think Dr. Bress did a great job pointing out the cost-saving nature of, say, icosapent ethyl. And so we try and surface that risk factor information in front of the physician at the time that they're seeing their patients. So diabetic, high cardiovascular risk, elevated triglycerides, they're definitely a candidate for this therapy. And given that we're in a prepaid environment, even if they have an event, we're not going to get paid additional money. And so really helping our clinicians understand that, and then maybe not forcing them into the pathway, but suggesting for them what those cost-effective alternatives are, has proved to be very successful for us.
Yeah, no, that's really useful info. I think one thing that's, at least for physicians to understand, and you mentioned in a prior segment the pharmacy benefits manager. I mean, I think that's a very opaque process. I think few physicians understand them, and even fewer patients understand them. I find it all a bit confusing to navigate, to be honest. But what are some of the challenges in terms of monitoring total costs and the issues? There are, of course, rebates and all sorts of things. Sometimes this makes it tough to know exactly who's paying how much for what drug. Is there any way we can just improve the transparency around all these issues?
Yeah, you bet. And I think one of the things that has been a trend within healthcare is employers and consultants have those people that are ultimately paying the bill carve out their services to multiple providers. And so the more you silo the care or the payment of care, the more you lose access to that data. And I think we've found that to be critical, that we need to have access to all the pieces of data. And so wherever we're the ultimate payer, and so we cover all the pharmacy costs, we cover all of the medical costs, we're directing them into our system. We have all those data elements, and we've worked very diligently over the last couple of years to figure out how do we bring that together. And in terms of, say, cardiology, how do we surface that information and let them understand exactly what is being spent per patient per month, and then identify within that some of those costs. And so as we talk about cardiology or cardiovascular costs, helping to surface for them this percentage of that per member per month cost that we're showing you is due to PCSK9 inhibitors. And this cost is due to some of the interventional procedures that have been done. And really helping them understand what are those cost-effective aspects, what are those initiatives or trends or pathways that they could follow that will ultimately lower that total dollar amount that we're spending. And I think if you take some of the work that's been done, say with Reduce It, to show great risk reduction, you couple that with some of the work that's been done by ICER and Dr. Bress as far as cost effectiveness, that now allows us, because we bucketed all the data into one place, to then surface these initiatives and these opportunities to deliver more clinically effective care to our patients, but do it ultimately at a lower cost and ultimately save us money over the long run as we treat these patients.